Hello and welcome to Pharmacologic Options for Veterinary Visit Anxiety and Evidence-Based Review. I'm Christy Keith, Senior Communication Strategist for Fear Free. Before I introduce our speaker, I'd like to take care of a couple of housekeeping items. First, we'd like to thank our friends and Fear Free sponsors at Zoetis Pet Care for making this webinar possible. We'd also like to thank all of you for making time for the webinar this evening. The recorded version of this webinar will be available usually within around a week. That may be slightly delayed due to the holidays, but it will be published at fearfreepets.com/webinars. 1 hour of RACE CE is available to veterinarians and technicians for this webinar, but only for those of you who are here tonight attending it live. There is no CE for the recorded version, I'm afraid. Immediately after this webinar ends, I'll be sending out an email to everyone who attended explaining how to get the CE. In it, there will be a link to a survey that you need to fill out. That survey is only going to be open until Tuesday afternoon at 3 p.m. Eastern. So please don't delay taking it. It's just 2 or 3 questions. It's very, very simple. It won't take you any time at all. And if you don't receive the email within around 1 hour after the webinar ends, you can email me directly at fearfreepets@gmail.com. Don't use the office email address, which is the WAG's email address, because they will not see it until tomorrow and then they'll just have to forward it to me. It'll slow us down. I will be looking at email this evening and we'll be able to help you right away. So one other thing that I'll just quickly mention, your CE certificate is available at a link in the final question of the CE survey. If you can't download it, for example, if you're taking it on your phone tonight, please click on that link and save the URL so you can go back and print it out later. You won't be able to go back once you've submitted the survey. And I want to make sure that everybody has the opportunity to get the certificate if they need it. And that's our #1 question that people ask me about their CE. Dr. Albright may have time for a couple of questions at the end. We're not sure. But if you do have questions during the presentation, please post them in the Q&A window as soon as they occur to you rather than hoarding them. And now all of that housekeeping is done, and it's my great pleasure to introduce our presenter tonight. Dr. Julia Albright is a diplomate of the American College of Veterinary Behaviorists and associate professor at the University of Tennessee College of Veterinary Medicine. She obtained both her master's degree in experimental psychology and her DVM from the University of Tennessee before completing a residency and fellowship in animal behavior at the Cornell University College of Veterinary Medicine. Dr. Albright has been in clinical behavioral practice for 13 years. Along with her clinical duties, she provides courses on small and large animal behavioral medicine and welfare to UT CVM students, as well as guest lecturing at other veterinary colleges. Her research interests include reducing stress in animal facilities, psychopharmacology, and the human-animal bond. Dr. Albright is also actively involved in national animal sheltering organizations. She is a consultant for the ASPCA and the current chair of the National Council of Pet Population, an organization dedicated to bringing research to the shelter community. She is also a Fear Free certified professional. Thank you for being with us this evening, Dr. Albright, and I'll be turning it over to you now.
All right, thank you, Christy, and thanks again for everybody for joining us tonight. So tonight is not quite just a discussion on what I do in the clinic, but pausing a little bit and thinking about what the literature tells us and to be using something called evidence-based medicine in choosing our pre-veterinary pharmaceuticals. So, first let's pause for a second here and discuss why do we even need pre-veterinary visit pharmaceuticals, which I'm just going to call PVPs from now on. And it's really nothing new to the folks in this audience, I'm sure, but the main points or the main reasons we use them are to increase the ability to handle our patients to increase safety for staff and our patients. But also we want to, not just those outward manifestations of fear, but we really want to decrease the animal's emotional state of fear and anxiety and stress. And what that does is not only for ethical reasons decrease the stress, but also help us the next time. If the animal's not so stressed this time, we're not going to have that fear conditioning, and they're not going to come in such a state of stress the next time. And then I wanted to bring up this really interesting study. It's in the Canadian Vet Journal, and all of these are listed in the references at the end of this talk. But these authors looked at the economic impact of manual restraint versus using dexmedetomidine and torb, and they looked at various doses. And they found that not only did using these medications increase handleability of their patients, but based on their calculations, they actually saved money by using less manpower to handle these really distressed animals. So the use of PVPs has greatly expanded in the last decade. And much of what we do on a day-to-day basis is absolutely based on trial and error and our anecdotal responses and clinical responses. But now the research is starting to catch up with this a little bit. So it's important to kind of pause and say, is what I'm doing really what's best for the patient that's in front of me? And what does the evidence tell me? And to best answer this question, I think it's important that we take just a little bit of time to review what is a good research study and what does a research study really tell us. Research can give us really reliable data, but not all studies are created equal. So I just want to take a minute to review the basics about research study design. And when you read a research study, how strong is that evidence and how much can you generalize that to your patient load? So this may seem strange, but you know, a good research study is supposed to be limited in design. It's supposed to not be able to tell us everything we need to know. And the reason for that is a good research study, it's in order to tell us if that treatment that we're interested in is creating a change, we have to only change one thing at a time. So what that does is so therefore, but it limits our ability to say, okay, but what about other populations, other environments, other problems? So things like the study population and the environment, they really need to be kept consistent so you know that your change is attributed to that variable of interest. So although the authors of a study can and should make some predictions about other possible applications, they really shouldn't be making strong conclusions outside of exactly what they studied. So for example, let's think about some studies looking at the effects of a certain medication on sedation and handleability of an anxious cat once they've arrived at the hospital. So these findings may only apply to cats with a certain level of anxiety at a certain dose of that medication administered at the timing that those authors used, and only for the handling that those authors used in that study or described in that study. So I'm sure you could see there's a ton of other factors, though, that would be really hard to control. So the genetic background of those cats, the household differences, how anxious is that cat in the car? You know, how much of it is the car versus the handling? You know, how much time did they sit in the waiting room? Exactly what procedures did they perform? I mean, it just goes on and on. So it doesn't mean that we can't apply findings more widely, but we just have to recognize that study is not really going to be able to tell us all that. And I want to mention too, take a little aside here and talk about what peer review means. So peer review is when you submit to certain journals, they ask, and it's on a voluntary basis, they ask people who have some familiarity with the topic, and of course those are not just some people, but those are usually researchers or board certified clinicians. And they're asked to do everything from point out really serious design flaws to is that the appropriate statistical test to word editing. So even though it's peer reviewed, there's obviously a lot of opinions and subjectivity that can go into that. So peer review isn't perfect, but I think almost everybody would agree it certainly increases the quality of almost every research project. But you just have to know that there's going to be some variation there. So it's really tempting as the reader of one of these articles is, just to kind of read the abstract and maybe skip to the discussion. But you really need to be able to read the results. And I know stats are pretty difficult for most of us, but you should be really critical in your assessment of the methods as well as what the author tells you. So when I'm reading a paper, I actually go into it with a really skeptical mindset. And I want those authors to convince me that they have a good study design and they've performed the appropriate stats test and they've made reasonable conclusions based on their study design and their findings, and they've identified the limitations to their study. So let's talk a little bit more about what evidence-based medicine is and how we can use this concept to make better choices. So as I mentioned before, that each study is pretty limited. So in order for us to get a more complete picture, you're going to have to do additional studies looking at all those other environmental possible variabilities and all those other populations and all those other problems. So that's, how feasible is that? That's going to be expensive and time consuming to go through all of those in a really systematic way. So evidence-based medicine is a term that is now used to describe, it's the integration of the best available research we have with our clinical expertise and the current situations of the patient and the client in front of you. So we're going to take a few minutes here and just to kind of go through the work of Dr. Susan Frick, and I apologize if it's Fricky. She is both a veterinarian and a librarian at the Washington State University, and she is one of the experts on evidence-based medicine. So this slide is just an overview of what we call the evidence-based clinical resource pyramid. And the strength of the findings of a study, they get stronger as you go up this pyramid. So the bottom of the pyramid is research that's focused on other species or not even conducted in an animal. So sort of like cell cultures, and those are important, but they're not going to be very applicable to us. So above that, which might surprise some people, but things like textbooks, experts' opinion, review articles, those are actually not considered very rigorous because the material may or may not be peer reviewed. You don't necessarily know the credentials of the authors. There may be some bias in there. And so moving up that would be these research studies. So we're going to take a look at those because there's a hierarchy within the research studies. The most rigorous studies, and those are on the right of your screen here, those are going to look at a very similar population. They're going to add or alter just a single variable like we discussed before. They're going to have both a treatment group but also a control group. And the subjects are going to be randomly assigned to those groups. And of course, you want both the researcher and the patient, or in veterinary medicine, that's going to be the client, you want them blinded to what's going on. So they don't know if this is a treatment or control group. So when you're then analyzing the data, you don't have that bias, either conscious or unconscious. But in medicine, it may not be, So in medicine, it may not be ethical to withhold a treatment, and the patients may receive some sort of treatment and then something extra or something different to compare against a new treatment or an old treatment. So again, I apologize for not advancing the slides there. So those are talking about the high quality, randomized, controlled, hopefully double-blinded studies. But at the other end are going to be case reports and case series, and those are considered less rigorous because they're not going to have a control group. But they're important because they it's letting our peers know of something interesting that's going on, something interesting we found in the clinic, and it should be further investigated. Case controls or cross-sectional studies in the middle there, those are helpful, but the problem is those are retrospective and looking back through the medical record or data to see if there's any difference between an affected group and some sort of non-affected group. But because those are retrospective, you're not going to be able to control for all the other factors that might be impacting the findings that you find. So again, they're not considered quite as rigorous as prospective studies, like the randomized controlled studies. But keep in mind, there's lots of room for varying study design or execution. So you might have, pretty poorly done randomized controlled studies that you can't generalize very well, or those are going to be weak studies. Whereas you might have a really well done survey or retrospective study that gives you a lot of information. So again, don't be a critical thinker and don't just blindly take what the author's conclusions, what they say their conclusions are. Read for yourself. So to illustrate this, why don't we look at 3 studies concerning the use of an alpha-2 agonist, alpha-2 blockers, but using them as an orotransmucosal route. And so orotransmucosal, by the way, just means that you're applying a medication to an animal's gum and it's absorbed through the mucosa, which we consider, of course, less invasive than giving the animal an injection, and hopefully stronger or maybe work faster than an oral tablet or capsule. So what do alpha-2s do? I kind of mentioned the alpha-2 adrenergic medications. They're used extensively in veterinary medicine in patients that have a stable cardiovascular status and no organopathy. And we use them to provide sedation or anxiolysis before handling procedures. And they work by blocking noradrenaline. So this study, back in 2013 from Hoppensperger and et al., her team looked at 6 lab dogs, but they were looking at the use of oral transmucosal detomidine for sedation. And they used a systematic protocol, a scoring protocol in 6 laboratory dogs. Now, this is an off-label use of this detomidine product that's approved for sedation in another species. But they knew that people had been using this in the clinic in dogs. So they wanted to quantify this and sort of put out there in the public sphere what's going on and how safe is it and how well does it work. So what they did is, again, they took these 6 laboratory beagles with a very similar genetics. They live in the same environment, and they had baseline assessment for all the dogs, and then they gave them the medication, and then they gave them then they assessed them in a similar way every 15 to 30 minutes after administration of the detomidine gel. And so they said, they rate their sedation, anxiety, and handleability score, and reported the difference in that at each point compared to the baseline. So they did find some side effects like low-level heart blocks, the expected bradycardia that we see from use of alpha-2 adrenergics. And then moving on to this study, this is Cohen and Bennett. This is a case report. Now they used the more modern dexmedetomidine, which is thought to be more potent and have lower side effects. And back in 2015, it had been used mainly as an IM and IV pre-med. But of course, that's not the most, it's invasive, it's difficult to give. And they knew that a lot of people were using dexmedetomidine rubbed on the gums or splashed on the gums. So what this team did is they wanted to, they published a case series looking at the effects of dexmedetomidine oral transmucosally in 4 dogs that were showing aggression in the hospital. So they reported the specific background, the behavior of the dogs, the doses they needed to use, the level of sedation, and any other adverse effects. So we're getting closer to our target population, you know, dogs in the clinic that are having agitation or aggression or anxiety. But the problem with this is there are no controls. But that was not, the purpose of the study was not to, you know, give us some sort of rigorous data, but just to put out into the public sphere what they found. It did work to provide some sedation. And so then they thought that that could be studied in a more systematic way in the future. So yet another study came out a couple years later by Corpivara and her colleagues. And this is a randomized controlled study using dexmedetomidine as a specific product called Celio. And it was described the same year, or described the reduction of anxiety and fear in dogs during firework events. So it's a fairly rigorous design. It's a randomized controlled, double-blinded, for pet dogs in the home, but we are relying on client reporting, and it's looking at the effects of a noise event, not at the vet visit. But owners did report that they had a lower FAST score, so fear, anxiety, and stress score, when the dog was administered the medication, the gel that had medication in it versus the dogs that had the gel with the placebo. So, and there were few reports of side effects. And something else to take away from this study, that reduced reactivity and increased handleability may occur independent of sedation. So that same team later that year, they presented an abstract using the same product. They were assessing the anxiolysis during a standardized vet exam as an off-label use of that product. So there's a short abstract that was published. It was a randomized controlled double-blinded study with 74 dogs, and the handleability was scored from 1 to 5, as from a placebo, the standard dose of this product, of the Celio, or a higher dose of the dexmedetomidine. So it is just an outline that we're able to read because it's an abstract, not a peer-reviewed study. So there's a lot more details that we'd like to see. But I can say based on this, again, I don't know what procedures they did. I don't know exactly what their scoring protocol was. But maybe some things we can take away from that are they report that the higher dose of dexmedetomidine was not more effective in this study than the lower dose. So again, that has not gone through peer review, so we have to be a little bit cautious about taking that to our patients in the clinic. So none of these studies, you know, really gave us a randomized controlled double-blinded study about dexmedetomidine or even detomidine in the veterinary clinic, either in cats or dogs. So each of them had some strong points. You know, one had a very systematic approach, but they were only using a small number of lab beagles, and it was using detomidine, but which doesn't mean we should shy away from that, but there are some concerns that it's not quite as safe as dexmedetomidine. Another one hit our target population of aggressive dogs, but there were no controls with it. That was the case report study, and it was a very small sample. The original Celio study for the noise aversion was a good study, but it wasn't quite for our target problem of vet visits. And then the one that was using Celio for the vet visits, it was not peer reviewed. We can't see the full study. So again, all of these have their limitations, but if we put them together, you know, the preponderance of evidence is telling us that, you know, alpha 2s, especially dexmedetomidine, used off label, is a reasonable and safe option to use for dogs. But of course, we'd like to see some more studies looking specifically at our target population and our target problem. So if we go back to this pyramid real quick, I just want to point out a few things that I wish I had known much earlier in my career. So there are some resources out there to kind of help you do what we just did, kind of go through the studies that are out there for particular problems, not just the PVPs, but any problem or any clinical issue that you're interested in. And one of them is, or a couple of them here, we call them CAT and VET. So CAT is the criteria for critical appraisement. And then I mentioned some others here, the Banfield Applied Research and Knowledge, Best Bets for Vets. And those, not only can you click on them here, but they'll be at the end in your references. And then something else, CAT is from the Royal College of Veterinary Surgeons, and this is their website, and they're based in the UK, of course. And they have a great website. So this knowledge summary in the bottom left corner takes you to the CAT. But they also have a toolbox that in general talks a little bit more about critical analysis of research studies. You can click this in focus, takes you to some synopsis of you know, some hot topics in veterinary medicine right now, and the studies that are out there. You can get the journals themselves if they're open access through that veterinary evidence journal link. So again, I think it's just a great thing for us to know about in veterinary medicine. And don't forget about good old PubMed. Your tax dollars at work here. You can see it's probably pretty small on the screen, but I just sort of typed in dogs and Trazodone, and it automatically applies an evidence-based filter for you. And you can also go to the main page and in the PubMed tools, click on clinical queries and type in a diagnosis or a problem of interest, and it will sort for you the best evidence, and then kind of put in a list for you from filter those for you. So I thought I'd just mention that because, like I said, I wish I had known that a long time ago. So what else is out there? Just to be complete, the synthesis level is, these are systematic reviews or meta-analysis. And if you haven't heard that term before, what those do is a meta-analysis is a research team that gather data about a certain topic or certain treatment or certain disease, and they gather the data and they do larger analysis on this large group of this large data set that's compiled of many different studies. So it's another higher level of analysis. And it's good to note that a systematic review is different than a review article, which again is kind of at the lower level here, that second tier. So it's considered much more objective, these meta-analysis, and much more. You can take those data, those findings, and be more confident about them. And just to kind of finish up the pyramid here, you can have a synopsis of the synthesis. So certainly you can have experts that got together and sort of helped you sort through some of those meta-analysis. And even higher up than that, or more rigorous, would be summaries, which are consensus statements from a larger group of experts who you know, they look at the research, they look at the data, they look at their own clinical experience or expertise, and they create things like white papers and state consensus statements or guidelines on a certain topic. And then the apex of the pyramid really isn't applicable to veterinary medicine. That's using computer support to help with decision making. And I think we're just barely scratching the surface of that in human medicine. And we're really just not even having that conversation in veterinary medicine yet, as far as I know. So I hope that quick review of the levels of evidence provided some clarification, but it's okay if it created more questions. I want you to see that there is some subjectivity in this quest for objectivity. And a research is really about probabilities. It's not really about proving anything. But what we do is we try to build a body of evidence with several different studies or many different studies to really kind of get to the answers we want. But let's kind of talk about what we have right now and turn back to the papers that are out there. And we'll talk a little bit here about cats. So Trazodone is considered, it's a very popular medication to use these days as a PVP. So what do we know about its use in cats? It is an atypical antidepressant, just to talk about the mechanism real quickly. It's also considered a SARI antidepressant, and that stands for serotonin antagonist and reuptake inhibitor. So antagonizing the 5-HT2A receptor is what is thought to create that calm and sedation. It does become a serotonin reuptake inhibitor like a Prozac or a Paxil, some of those SSRI antidepressants, when you use high doses for longer periods of time. And in addition, it is an alpha-1 antagonist. It has some antihistamine effects. Some papers say it has a GABA agonist effect. So those can all create kind of that sense of calm and sedation as well. So Dr. Stevens, a couple years ago, did a study looking at cats, before a vet exam. And so she and her team gave the cats 50 milligrams of Trazodone prior to transport and the vet visit. And their measurements were client and clinician assessed cat anxiety and sedation on a scale of 1 to 3. So both parties were blinded, so that's a good thing. And the cats received both a placebo and the treatment. So again, that's what we call crossover design is desirable because it compares the changes within an animal. And when you put different animals in different groups, you always have this niggling concern that maybe their baseline wasn't exactly the same. But that's not a problem in this study. And they found that the Trazodone was linked to a significant reduction in anxiety scores from the client and clinician. So I did want to take just a second too to talk about what a p-value means when you're reading a study. What can you learn from that? So the p-value is what we look at to describe or to determine if there's a significant difference between groups. So in most fields, there's this kind of agreed upon magic number, 0.05. And what that means is that the risk that difference between or among the groups is less than 5% that difference is due to chance. So the lower that number is, the lower that risk is to chance. So that's a stronger finding if it's lower than 0.05, or the lower than 0.05 it is, the better, I guess you could say. So you got to read carefully though, even though that isn't, most studies have that 0.05, some don't. Some researchers will decide that they feel like their design warrants a 0.1 or a 10% chance. So to you and the reader, that may mean this is a slightly weaker study design, or question why they did that. So something else to think about is, so what if it's 0.051? Does that all of a sudden mean that these data are not, this treatment is not effective? Maybe not. You need to look at a lot of things like sample size, because a low sample size can affect the p-value and potentially mask true differences. So other studies have looked at Trazodone use in cats. Orlando et al. They used various doses of Trazodone, but they looked at laboratory cat activity based on activity monitors, so an objective measurement of how much these cats were moving in addition to the behavior during a set kind of fake vet exam. So they did find that the 50, 75, and 100 milligram Trazodone did significantly decrease activity level in these cats compared to placebo. But they did not find, based on their scale, that these differences kind of made a difference in the vet exam. So things to take away from the study for me were that up to 100 milligrams of Trazodone does seem to be safe in cats. It's interesting too that the activity level with the placebo actually spiked 14% compared to the baseline. So that's why things like placebos are so important, because you need to know what just giving the pill, or what if the owner thinks that they've gotten something, what does that do? Your changes may not be just from the drug. So the preponderance of evidence is that Trazodone does seem to be safe in cats. It did not change the FAS scores, or the fear, anxiety, and stress scores of these cats, of these lab cats, compared to the owned cats in the study I just mentioned before. So what does that mean? It may mean that the scale is not sensitive enough for these laboratory cats, although a similar one was used for the owned cats. But again, I feel pretty comfortable prescribing 25, 50, or 100 milligrams of Trazodone to my feline patients prior to travel, prior to the vet exam, even though neither of those studies really looked at all of those factors at once. So another takeaway is that the authors suggested testing the cats individually to find the best peak time for that specific cat, because these authors say that it varied quite a bit. So gabapentin is used very, very frequently in our clinic. I know my colleagues are using it a lot. I know those of you out there telling me are using a lot. So gabapentin, what exactly is it? It's not, there does seem to be not 100% agreement in the literature, but it is a GABA. It does look like GABA. It is debatable whether it acts like GABA, but it does, some authors say that it modulates actually calcium channels, but nonetheless, it does seem to produce a state of calm and relaxation, as well as decreased pain. So Dr. Van Haften, a couple years ago, looked at this in cats to see if this would be a good PDP for that species. And she just took a single dose of gabapentin, 100 milligram capsule, and compared it to placebo in cats. So it was a crossover design prior to transport and the vet exam. This was also a pretty strong study design. It was a randomized control, double-blinded, placebo-controlled, and all, just like the other 2 or 3 that I just mentioned, those were published in peer-reviewed journal articles or journals. So the results of this is the client-owned cats did show sedation and increased handleability based on owner and vet scores. This team also added an objective video score, meaning that somebody that did not know what was going on with the cats was asked to look at this clip and score it. In those, they did not find any difference. So that's interesting. And what does it mean? Does it mean that the owners and the veterinarians, that was just wishful thinking or a placebo effect? Or is there something that the video is missing? So the authors did bring that up, and I think that is a valid question. It doesn't mean that we throw out that real-time client and clinician data. They may just know that cat better, and they may be able to pick up on more subtle differences. But we do have to kind of think about all the possibilities why those don't agree. But again, I think the take home from this, for those of us that do use this in the clinic, is I'm going to continue to keep using it. We do need to expect that some cats may vomit, some may have some pretty significant ataxia. And just like with the Trazodone study, Dr. Van Haften's team found that there was a pretty variable onset time with gabapentin. So it just confirmed what I do, and I feel like most of us should do too, is really ask these clients to be giving test dose and to test to see when their cat has a specific peak in sedation effects, and therefore it will be most effective when we need it in the clinic. And also looking for those side effects. So if it's a cat that has agitation, or a cat or a dog to Trazodone or Gabapentin or anything else, we'll know that ahead of time. And yet another study in cats, Pancrats in 2017 looked at the use of placebo, 50 milligrams or 100 milligrams of gabapentin on the anxiety level of feral cats. And she found that there was no difference in physical or behavioral indicators of distress amongst the groups. But again, it's a good reminder that you can't necessarily extrapolate findings from one population to another. So even though it was looking like there was some beneficial effects to gabapentin in the owned cats, in these feral cats, in this stressful situation, gabapentin doesn't seem to be making much of a difference. But for those of you that might be working in the shelter, perhaps the way you do things, you are seeing a difference. So you just have to look and see, what are they doing? What are their protocols? What could we potentially change that we might see a difference? But you might also ask, all right, we're not seeing really strong results. They didn't find really strong results in their feral cats either. Is this something we should be putting our resources into? Just a couple of other studies that I came across. Dr. Landsberg has presented some studies where he looked at, he kind of compared gabapentin and dexmedetomidine in cats. So again, this is an abstract, so this is not a peer-reviewed paper, but it appears, so he gave either 0.25 milligrams of that should say dexmedetomidine gel, or 100 milligrams of gabapentin or a placebo capsule. So we do have, it's a double-blinded study, it's placebo controlled, and the results, and he put them through a 10-minute car ride, and these were all laboratory cats. And a marker of stress, which is cortisol, did decrease in both the dexmedetomidine gel group and the gabapentin group compared to the placebo. There were some decreased stress behaviors, but it was interesting, different things happened in different groups, but both groups had some changes compared to placebo, and there were very few side effects reported. So as I mentioned, sounds like a promising study. Unfortunately, not much we can do with that right now, because it wasn't peer reviewed. It would be great if we could see the details. And again, I apologize, it's incorrect on this slide as well. That should be dexmedetomidine oral transmucosal gel and 100 milligrams of gabapentin. And there's no real winner that I can see based on this study. So what about, we've been talking about gabapentin and trazodone in cats. What about dogs? We use it all the time, but I was pretty surprised. There's no studies at this time for the use of either of those as a PVP in dogs. Dr. Gruen at NC State has, she had one of the first studies out on trazodone, and it did seem to be effective for chronic anxiety. She also did both of those studies, this study and her original chronic anxiety study, were both open labeled studies. So that means there's no control, but looking at post-surgical sedation, using trazodone for post-surgical sedation treatment. And she did find that there were some promising results from that. And I believe that Fear Free is funding a study from UC Davis looking at trazodone as a single agent PVP in dogs. So we look forward to seeing what they find. So that's kind of a review of what we know about the common PVPs in dogs and cats. So now I want to get into what do I do, and kind of weave in there the research and what's my clinical opinion. So in dogs, the first line, you know, and we also need to talk about single versus combination. Not only is there not a lot of data out there on single agents as PVPs, but there's really not a lot of data about using them in combination, especially as an oral medication. Now, the anesthesia literature, there's lots out there on using these as injectable, but that's going to have a potentially different PK and pharmacodynamics as well. But we are going to, you know, we do extrapolate to this point. So if you're kind of wondering what we, you know, what's common, what I use, Trazodone is still one of the first things I aim for when I am encountering a dog that needs something before the vet visit. I always have the owner give a test dose. I'm usually aiming for that 5 mg per kg. Depending on the animal in front of me, I might aim a little lower, or I might go a little bit higher, depending on the animal and how urgent the situation is. If there's no agitation, there's no GI side effects, we'll talk about should we use it just right before the visit. And by right before, I mean, you know, that 2 to 3 hour sweet spot. I would say in almost every case now, if I have the option, I'm also doing an additional dosing 8 to 12 hours before. And of course, we're doing lots of things. We're not just talking about, that's not really the point of this, this webinar tonight, but it's so important to be thinking about the fear conditioning that might be happening with and doing your happy visits or your victory visits, getting the medications into the animals with some desensitization and counter conditioning. Both to the medication administration and to the clinical environment, to the handling, all of that. I want to emphasize that it's not just all about the medications. So I'm going to be talking about Celio here. And just a reminder that this is all off-label. That is an FDA-approved medication for noise aversion. I'll let you read here that it's, you know, it's a norepinephrine blocker. Just a reminder that it really it's an anxiolytic dose, not a heavy sedation, because one of the reasons is it only has 28% of the bioavailability of that same amount if you were to give that as an IV. Expect some bradycardia and hypotension. If you're not going to use dexmedetomidine injectably, we don't want to use Celio. And if you're curious, you can redose it as soon as every 2 hours, up to 5 doses within a 24-hour period, if the symptoms are, if you need it again. So I'm not going to read this slide, but I'll give you a second to kind of scan it there. Do take note of the website link there at the end. So if you wanted all this again, including some really excellent dosing instructions, because that tube can be a little confusing when you first look at it, but it's really not once you get the hang of it. That's all. They have a great website there. You can certainly use off-label oral transmucosal dexmedetomidine in appropriate stable patients at the recommended doses. Again, there's that study and a lot of clinical evidence to support the use of datomidine, oral transmucosal datomidine, in those same appropriate stable patients. Other options, and I have to say this is probably my go-to, is I'm just working on getting an injection into that animal right off, and dexmedetomidine and torb at these, you know, really kind of normal doses, mid-range doses, usually get the job done for us. But you certainly could go up to your 10 mics per kg of your dexmedetomidine. If you felt like you needed to, say, front load this animal, that you needed him to be a little bit more sedate before you got the injection into him, You can absolutely use a higher dose of some of your oral or your dexmedetomidine oral transmucosally, but that does mean you should lower the dose of dexmedetomidine that you're giving in your intramuscular, or in most cases we're not getting anywhere close to a vein to do IV with these guys. Or alternatively, you could still use your a high dose of dexmedetomidine oral transmucosally, but use your toledione, zolazepam IV, or your Tilazol. But of course, that's not reversible, unlike your dexmedetomidine. So all of these medications I have on this slide, I use on a regular basis in various dogs due to trial and error as PVP options. I use almost all of them in some dogs as combinations. I guess the only ones I would not use, I would look and see, especially the hypotensive aspect. So I'm probably not going to be using, say, clonidine and acepromazine together. And also, giving repeated doses can be very helpful. Giving that dose the night before or the 8 to 12 hours before can really kind of cover that animal when they're starting to see that the car ride is imminent. All of those things, even if they're happy to go into the car, they just add to the excitement and arousal and the decreased ability to effectively sedate that animal. So just to kind of complete what's on the slide here, we got clonidine, gabapentin, one of your benzos, probably alprazolam and diazepam are the ones that I go to the most for giving the client a tablet that they can give the animal at home. Acepromazine is always that controversial topic. So I certainly do still use it. I know that there's, Tufts has their chill protocol. This is just part of it. So I do still use it, especially if there are animals that there's a history of this being a successful medication for them, or we need to top off, things aren't going very well and I need an additional medication. You'll notice here I have a dose for both an oral, but also splashing that injectable using that oral transmucosally, I have to say, is much more successful in my hands than giving it as a tablet. So I'm going through all these, I'm telling you about what I use, but it is important to know we have no studies on any of these for use as a PVP in dogs. But we do have data to show that at least alone, some of these in combination, they should be at least safe for your animals, for your patients. Again, I'm being a little careful about, say, acepromazine and clonidine, things that I know are both hypotensive agents. Let's talk about cats real quick. Always, those studies told us that cats are going to have variable sweet spots. Sometimes 90 minutes might be fine, but sometimes you might need up to 2.5 hours for your PVP your oral PVP to work in your cats. So gabapentin 100 milligrams is probably still my go-to. Some cats, though, around 25, 50, 100 milligrams of trazodone 2 to 3 hours before the visit works pretty well. We're starting to use a little bit more of the off-label Celio, again, kind of based on the studies that at least say it's safe and there may be some benefit to it. My combo as of now, though, I've been using gabapentin, the 100 milligrams, and trazodone, dosing them together. That's been working very well for me and these really nervous kitties. So again, that's kind of my second line, which I have to say is almost moving up to first line at this point, is using those two together. That should be safe, even though we do not have studies about the use of both of those together. And I'm also starting to do a whole lot more of the double dosing. So not just 2 or 3 hours before they get in the car, but also 8 to 12 hours before they get in the car. And then your second or third line in your cats, of course, is we've got a lot more problem with being able to get these pills into cats than we do in dogs. So sometimes this is the first line option in the cats, depending on what the clients are able to do with them. But kitty magic, quote unquote, which is some combination of an alpha-2, a dissociative like ketamine, and an opioid. Still very successful for us. So you can see the doses here that are just, they're published in a lot of places. And then splashing that on the cat's mucosa can often make that cat much calmer and more sedate and more tractable for our exams. So in conclusion, look at your studies are important. They help guide our decision making, but at this point, they just really can't be the only answer. No one research study is going to give you any sort of answer. It just sort of starts to build the story. Like I said, I really wish I'd known about some of those web-based assessment tools a long time ago. That those are not, I feel like we can put a lot of trust into a lot of those. But we take the data, we also look at the patient in front of us, and of course we don't throw out our experience at this point. We just don't have enough data to really fill in all those holes. So real quick, I'd like to acknowledge and thank both Fear Free and Zoetis for bringing this, this presentation to you. I'd also like to thank my research librarian, Miss Ann Vieira. She is the one who both for this presentation and through vet school and through the last couple of years has really been very valuable at emphasizing evidence-based research and decision-making. And then I should also note, Fear Free has a fabulous archive of these studies, or at least the references and the citation for them. So if you go to this link, if you look at fearfreepets.com and go to Fear Free Research, you can see you can click here on the different studies. So you can see the study. A lot of them are open access now, so you can actually look at the study itself and then maybe use some of what you've learned today to critically read these and pull from them, and what you pull from them and make some decisions based on that. So here are the references for those studies, and I'm happy to entertain any. I think we got time for 2 or 3 questions maybe, or I'll let Christy decide how many we've got here.
Okay, great. Well, thank you so much. That was fantastic. I'll just jump right into the questions. The first question is, what parameters are you asking clients to watch for when doing a test dose, as these dogs and cats are usually fine in the home environment?
That's a great point. So I'm not really looking for how are they going to do in the clinic. I'm making sure these animals don't have those agitation side effects, some really terrible diarrhea or vomiting. Sometimes that's expected and it's not a deal breaker. But I should say the GI issues, the agitation always is, because the agitation is typically idiopathic. It's usually not a dose or a trigger thing. So you can at least rule out the medications that you don't want to use. And you can get a better idea of the timing. So is this cat really sleepy, cat or dog really sleepy at 60 minutes, or are they still walking around 2 hours later?
Great, thank you. Can you use Trazodone, ACE, and Gabapentin all together? And if so, how do you calculate the doses? And they didn't ask whether that was for a dog or cat, but I assume this is for a dog.
So let's start with a dog. I have used those together, and I typically would be using the Trazodone and the Gabapentin first, and then adding that ACE promazine on if I needed it, sort of that injectable splash on the mucosa. I have not done that in cats. And again, there's no studies on that to really tell us if that's safe or not. I have no reason to believe it's not safe, but again, I'm being a little bit more cautious in my feline patients. And remind me what the second part, dosing. So most of these do not impact each other, meaning sure, I start at a lower dose if I need it, just to make sure I'm not walloping the animal sedation wise, but I have to tell you, more often than not, I am using the full dose of both medications, and it seems to be perfectly safe. So it's just a matter of kind of the optics of how sedated the animal is, kind of when the owner takes them home.
We actually got two questions about the use of phenobarbital in combination with gabapentin in dogs or just in general.
So I have heard quite a bit about that. I feel like it was fairly popular 2 or 3 years ago. And again, it doesn't mean it's not, but I'm hearing less about it. And I just feel like there's one clinician here at UT that used it quite extensively. I feel like it's quite safe. It is not very effective in my hands. So again, no studies on it really. Seems to be safe. Maybe there's some better things out there on the horizon, but if this person is having success with it, I've got no data to say that they should stop doing that. Is that sufficiently vague for everybody?
Yes, you did an excellent job. So that's really all we have time for tonight. I want to thank you again, Dr. Albright, for being with us, to everyone who attended, and to Zoetis Pet Care for making this presentation possible. This was the last Fear-Free webinar of 2019. We wish you all a wonderful holiday season and a happy new year, and we'll see you when the Fear-Free webinar schedule picks back up in 2020, which just sounds like it should be at least 10 years in the future instead of a couple weeks. Thank you again, everyone, and keep an eye on your email box for your CE survey, which will be going out almost immediately, within less than a half an hour. Thank you so much, everyone, and good night.